in the country. The amount of suffering that I've encountered in our women from pre-eclampsia is heart-wrenching. Every day when you do round day, you see pre-eclampsia, you see women with renal failure, secondary, intractable renal failure, secondary to pre-eclampsia. When I do my work in the fetal maternity unit, the number of fetal growth restricted babies that I encounter, the abnormal Dopplers, the babies we have to recommend delivery, knowing that they are not going to stand a chance in our neonatal unit because our neonatal unit is not able to handle babies of a certain size, is alarming. And the amount of IUFDs that we confirm during those scans is also alarming. So for me, I've come to realize that there's no way to hide. We have to take the pre-eclampsia challenge because pre-eclampsia has caused untold suffering, is causing untold suffering amongst the women in our region. I'm glad that I'm not the one who's starting this challenge. FIGO has already pronounced it as a challenge to say predicting and preventing pre-eclampsia, the challenge. One of the reasons why FIGO declared it this way is because pre-eclampsia affects between 2 to 5% of the pregnant population. And in our region, in Africa, it can range from 8 to 12%. As a result, 76,000 women die every year from pre-eclampsia. But the most worrying bit of pre-eclampsia is that it's not just the deaths, it is the morbidities that are associated with it. So that overall, it has been shown that women who have preterm pre-eclampsia, that is before 37 weeks, they have their life expectancy reduced by an average of 10 years just because they've developed pre-eclampsia. This is how ravaging pre-eclampsia is. And in our country, to all my colleagues who do ward rounds in our antenatal wards and the labor wards, pre-eclampsia probably occupies 80% of our beds in our hospitals. Then globally, 500,000 of babies die from pre-eclampsia, which is very alarming to know that 500,000 of the babies are dying from pre-eclampsia. As a result, this is a challenge that everyone who works in women's health has to take and fight the pre-eclampsia scourge. So if we come back to our country and look and say, what do we have in terms of why are women dying in our country? There's no question that obstetric hemorrhage remains the leading cause of why women die in our country. But if you look at pre-eclampsia, and the whole hypertensive disease in pregnancy spectrum, it contributes close to 20% of the reason why women die, which is the second commonest known cause of death in pregnant women. So it is a very important condition in our country. But the question is, what are the demographics of our pregnant population? How are they behaving in terms of, are they booking? From the Ministry of Health data, 82% of the pregnant women have antenatal visits, and of those 82, 87% of them attended at least 4 antenatal visits. So what does this mean? That means we have a window of opportunity to do something to the pregnant women, because if 82% of them who come get the right kind of care, we can, in a way, make an impact in reducing the incidence, especially of preterm pre-eclampsia. However, what is saddening is that only 30% of them book before 16 weeks. So this therefore means that we are a little bit stuck in 1929. Professor Kypros, Nicolaides, over the years has campaigned to the whole world that we need to turn the pyramid of care so that women are seen early, so that all obstetric investigations and the interventions can be done by 12 weeks, so that the high-risk group can be identified and be given specialist care, while the low-risk group continues in the routine care. But
كده بيذبحوه كده بيذبحوهم. ايوه طبعا ما انا بقول لك مشكلتنا اصلا دايما في الطب او الكليات العلميه.
Muting that, sorry. Right. So in our region, we are still stuck in 1929. So this is one of the biggest challenges we have to take, to say we need to promote early booking of the pregnancies, because if 30% of the pregnancies only booked before 16 weeks, this therefore means that the first trimester investigations and interventions will not work in our setting with this kind of booking in pregnancy. This is probably mirrored in most of the regions in Africa. So this is our first challenge, to say we need to turn the pyramid of care. The progressive world or the developed nations, most of them have turned this pyramid of care, but we are still stuck in 1929, where most of our women present around 16 weeks. So this is the first challenge which we need to address. Then when you look at why babies die, I know the song of preterm birth as the leading cause of death has been going on and on for years, is the same story in developed nations. But what is interesting from our data here in Africa is that a third of the babies die from birth asphyxia, and almost 20% of them die because we don't know why they are dying. But the true story is that most women barely have an ultrasound scan. In our country, probably all they did was scanning until a few months ago. So they barely have an ultrasound scan. So what does this mean? This then means that there is hidden mortality from preeclampsia in these two groups, which is underreported because we are just lumping it as birth asphyxia and also unexplained intrauterine fetal demise. How do we know this? We know this from our work, which we have done in the fetal medicine units, the 2 fetal medicine units so far. Since we opened the fetal medicine units 18 months ago, we have scanned consecutive 2,713 women using Fetal Medicine Foundation protocols, where we diagnose fetal growth restriction following strict Fetal Medicine Foundation protocols. So we have noted that of these 2,713, almost a third of the women, about 30%, 26% of them had preeclampsia. In the preeclampsia group, 41% had fetal growth restriction. The practice is such that most women with preeclampsia, they are normally induced with cytotec, which is misoprostol, a very dangerous drug for a baby who is hypoxic from placenta insufficiency. So this is where this hidden mortality is. The service that we are offering is not offered in the rest of the country, where precise diagnosis of fetal growth restriction done, all the fetal Dopplers are done, and the high-risk babies are triaged to make sure that they are not induced, instead they are offered cesarean. So because of that, our national mortality figures, they are hiding these babies who are fetal growth restricted from preeclampsia, and they're just lumped as birth asphyxia and unexplained IFD, more so if it is late onset fetal growth restriction. So preeclampsia is a bad issue for both the mother and the babies in our country. But our ministry has already published some key interventions that we believe they will improve the perinatal and I believe also maternal outcome if we follow this intervention. But these interventions, they have a weakness which I will highlight just now. So one of the statements on preconception intervention for preventing neonatal morbidity and mortality is that we should assess and grade pregnancy into either high risk or low risk at booking, which is perfect. This is how modern obstetrics should be practiced. High risk group should be identified and be given specialized care instead of lumping everyone in the same group and giving them the same care. But go on to the preeclampsia page to say, then what should we do? Because we recognize as a country that preeclampsia is a big issue. Then on the preeclampsia, in all pregnant women with risk factors for preeclampsia, especially women with the history of previous preeclampsia or eclampsia, give 1.5 grams calcium per day orally to prevent hypertension and preeclampsia throughout pregnancy. Started the first contact with every woman at high risk. Probably the problem is here. Yes, calcium has been shown to be effective in women who have a deficiency in calcium, but the criteria we are using, which is only history-based, unfortunately, it has been tested more so if we look at the testing, which was done with the NICE guidelines and also the ACOG guidelines, we show that at best, if we are going to use the history of the woman, we are probably going to pick around 30% of the women who are likely to develop preeclampsia. which is a problem, because if you are only going to pick 30% of the women who are going to develop the disease, that means the 70% are not going to get the right intervention, and they are likely to be given a wrong kind of antenatal care follow-up. Then preventing preeclampsia with aspirin. Give prophylactic aspirin to all pregnant women with high risk factors for preeclampsia, especially those with previous history of severe preeclampsia or eclampsia associated with IUGR or IUD. Again, this treatment should not be different. It should be the same, because if we are going to identify the same group of women, then this treatment should be the same. And again, it is only history-based, which is a problem. Then prophylactic aspirin is known to prevent preeclampsia, premature delivery, low birth weight, and perinatal mortality. Give 75 to 100 milligram day of aspirin orally throughout pregnancy. This treatment is there, but it does not state when it should be started. From the data which I did not show you, which we collect whenever we see women in fetal medicine unit, you discover that most women with these risk factors are actually not getting the aspirin at all. Even the 75 they are not getting it. We know that the 75 does not work as good as the 150, but still the 75 is not, they're not getting, because it's not very clear in the guideline when should they be given. Some are given even in third trimester, which does not make sense to give them in third trimester, or when they have already developed the disease. Then our book, we have an antenatal care book, which is used in our country, and my colleagues know that's the brown book. When you open that brown book, overleaf on the page, there are certain questions that have been put there, which all health workers who attend to pregnant women have to assess. Then it is written on the top that if there is a yes to any of the below questions, I've just taken the ones which I think they are trying to screen for preeclampsia. I left the other ones which have nothing to do with preeclampsia. It says if there is a yes to any of the above, refer for specialized care. Stillbirth or newborn loss, birth weight less than 2,500 grams, last pregnancy admission for PAH or preeclampsia, diastolic blood pressure greater than 90 millimeters of mercury, and diabetes mellitus kidney disease and cardiovascular disease. So this is all we have in our book to screen for preeclampsia, to identify women who are at risk group. The question is this screening adequate? What is how many women are we going to detect with this kind of screening? So this is where we need to take up the challenge. We need to change this, but this is not going to be enough. This is a little bit inadequate in trying to identify the at-risk group who are going to develop preeclampsia. But this is what is being used nationally in all our antenatal clinics, or pregnant women who are go for antenatal visits. About 2 years ago, the Aspre trial was published, but when it was published, who gave also almost at the same time they published a guideline where they were mentioning the preventing strategies. Although the preventing strategies are not very clear on how to identify the at-risk group besides the history, which we have mentioned. But they do acknowledge that the majority of deaths related to preeclampsia and eclampsia could be avoided if women received timely and effective care and delivered according to evidence-based standards. But the other guidelines, like the ZSOG, they have since recognized the impact of the Aspre trial, and they've come up with guidelines that mention the role of ultrasound in screening for and follow-up of preeclampsia. This will be discussed later. Then FIGO as well have come up with what we call pragmatic guide for first trimester screening and prevention of preeclampsia. So they've come up with various kind of models that countries can adopt depending on their resource and also depending on their situation. This will be discussed. So because these guidelines, the new guidelines which are now there, they really emphasize that uterinatal Doppler is a very important biophysical profile to be used in the screening for preeclampsia. If we look in the national context of Zimbabwe, can we offer screening for preeclampsia? Admin, thank you. If we if we are to offer screening in Zimbabwe, a lot of training has been happening in the last 18 months in terms of ultrasound, so that 66 of our districts have already been trained in basic skills, and 8 provinces have been trained also in basic skills through the support. The ministry has partnered this wonderful organization, the Fetal Medicine Foundation Zimbabwe, has supported us to train at a high level at central hospitals, so that the 2 of our hospitals have adequately trained staff who can now do uterinatal Dopplers. UNICEF has been supporting the training at district and central hospital, including supporting the Ministry of Health and purchasing the machines to be used there. While the Fetal Medicine Foundation has supported the machines that we are the machines we are using at training at tertiary hospitals. So there is a training which is ongoing, which we hope to advance to the level where our hospitals, probably provincial hospitals, are able to do uterinatal Doppler. But the machines that are available in district hospital, most district hospitals, are entry-level machines which will not be able to do uterinatal Doppler. So we still have a skill deficiency in trying to implement, including the uterinatal in our algorithm for screening for preeclampsia. We are doing it in fetal medicine units, more under research setting, but in wide application, we'll have this kind of a challenge. In terms of the laboratory support, these biochemical markers have been identified to contribute in the screening for preeclampsia. That is PAPE, soluble in FMS like tyrosine kinase 1, SFLT1, and PLGF. But however, currently, our samples are being exported and the price is exorbitant. Just as an example, PAPE and BTSCG for screening for aneuploidy as biochemical markers cost around 70 US in our country, which is around between 55 to 60 pounds. So this will remain sort of an impediment in wide application of the biochemical markers in screening for preeclampsia. So these are the challenges which we believe we need to address as a challenge. We need to address the knowledge gap. The training from medical school to the schools of midwifery has to change and to adopt more of preventive obstetrics than the reactive obstetrics, which most trainings are currently doing. So that there's very little emphasis on strengthening the prevention strategies as far as the preeclampsia disease is concerned, rather than the management strategies. Then the inadequate equipment will also need to be addressed, and the skills gap. The skills gap we are talking of here, we're talking of the skills gap of ultrasound, that the ultrasound scan performers in our country need to be upskilled so that everyone can be able to do uterine artery Doppler as part of screening for preeclampsia. Then the laboratory shortcomings, of course, we are still in discussion with the laboratories to say, why are we exporting samples? Because this is making them expensive instead of just doing them locally. I think this is my presentation. Thank you so much for taking time. And I want to thank the team which I work with in fetal medicine unit, and the team was in Alcande there with Professor Kypros. It was a wonderful time. Thank you so much. Thank you for listening.
Thank you, Dr. Verenga, for that insightful presentation and for your work in spearheading our obstetric practice from 1929 archaic practice to more modern practice in Zimbabwe. I will now allow the participants to comment or pose any questions. You can use the chat function or raise your hand. Dr. Georgievich, you can go ahead.
Thank you very much for the wonderful presentation, Dr. Verenga, and we are all taking our hats off for what you're doing for us and for our country. Placental growth factor, how far are we? I know that you know that I'm going to ask this question, but I'm asking every year on and on, how far are we with the testing of placental growth factor in the first trimester? Thank you.
Thank you, Dr. Georgievich, and thank you for supporting fetal medicine so much in every way. I think the ball is in the laboratories. The laboratories, we had invited them. I'm not sure if they are here, But the laboratories were in discussion with the laboratories, and also Pekin Elma, who will present later, will also chip in and say and tell us how best they can make it happen for us in terms of providing affordable kind of solutions for screening for preeclampsia, because the current solutions which are there, where we are exporting samples to South Africa, will always remain a challenge. This is the same challenge we are facing with combined screening tests for Downs for women who choose to have it, that the 70 US they are being charged. It's a little bit deterrent for the women to uptake the test. So the challenge is still in the laboratories' hands, and we are in discussion with them, Dr. Dev. Thank you.
Thank you.
Do we have any more questions or comments for Dr. Verenga? Thank you once again, Dr. Verenga, for that clear and insightful presentation. I will first confirm the presence of our next speaker before we move on to our second talk in the session. Okay, so today it does feel like we are at the Oscars and Grammys of obstetrics and gynecology, where we are audience to the stars in the field. And I'm absolutely delighted to welcome our second speaker. Our second speaker is Professor Kypros Nicolaides. He's a professor of fetal medicine at King's College in London, which is in the top 10 universities in the world. Prof. Nicolaides is also the chairman and founder of the Fetal Medicine Foundation that aims to improve the health of pregnant women and their babies through research and training in fetal medicine. He pioneered screening for Down syndrome using the nuchal translucency measurement, and he also pioneered the screening for preeclampsia in the first trimester. He has also published more than 1,450 peer-reviewed papers. I present our esteemed guest, Prof. Kypros Nicolaides, who will give us lessons from the Aspre trial. Prof, if you can connect. So please bear with us. We are currently trying to make sure that Prof is online and well connected.
Thank you, Dr. Banzura. Maybe we can take a few questions, comments to the previous presenter while we sort out. I think we can. I think we can now see Prof. So let's give him a chance to connect. Thank you.
Hello.
Good morning, Prof. We can hear you loud and clear.
Great. Thank you. Thank you very much.
You probably need to share your screen.
Yes.
Okay, thank you.
Just see what's...
While you're setting up your screen, Prof. Nicolaides, I will reintroduce you. As I said, today it feels like we're at the Oscars and Grammys of obstetrics and gynae, where we are audience to the stars in the field. You've been one of them. I'm absolutely delighted to welcome you as our second speaker. Prof. Nicolaides is Professor of Fetal Medicine at King's College London, which is in the top 10 universities in the world. He's also chairman and founder of the Fetal Medicine Foundation that aims to improve the health of pregnant women and their babies through research and training in fetal medicine. He pioneered screening for Down syndrome using nuchal translucency measurement, and he's also pioneered the screening for preeclampsia in the first trimester. He has also published more than 1,450 peer-reviewed papers. I present to you our esteemed guest, Prof. Kypros Nicolaides, who will give us lessons from the Aspre trial. Prof, you can go ahead.
Thank you very much for your nice introduction. It's a great pleasure for me to be able to communicate with friends in Zimbabwe. I hold dearly in my heart Zimbabwe because when I was a medical student, my best friend was a doctor from Zimbabwe in London at King's College Hospital. And I have followed up the developments in your country in the last 40 years with a lot of interest and a lot of love for your people. So I will be discussing, yes, lessons from the Aspre trial in terms of prediction and prevention of preeclampsia. And just to remind or tell the audience, what is this Aspre trial? It was a multi-center study in which we carried out screening for preeclampsia in nearly 27,000 pregnancies at 11 to 13 weeks. And then we identified a high-risk group based on this method of screening that I will be discussing later. And then in the high-risk group, we randomized them into aspirin or placebo. And the aspirin, the active component, contained 150 milligrams every day, taken from 12 to 36 weeks. And as you can see there, the study was carried out in centers in Spain, Belgium, Greece, Italy, and England. The results that were published in 2017 in the New England Journal of Medicine showed that with this treatment, we could reduce the rate of preeclampsia before 32 weeks by nearly 90%, the rate of preeclampsia before 34 weeks by about 80%, that of preeclampsia before 37 weeks by 60%, and there was no significant reduction of term preeclampsia. So this is a prediction and prevention of preterm and especially early preeclampsia, which of course is the most severe in any case. So what is the story behind all of this Aspre trial and what are the implications? Well, the story is that in England, in the United States, probably Zimbabwe and everywhere else, the method of identifying a high-risk group for preeclampsia is based on maternal history. And there is a common feature in this type of scoring systems that you use a history of previous preeclampsia, chronic kidney disease, chronic hypertension, diabetes, lupus, and antiphospholipid syndrome. And these are considered to be absolute high-risk factors. So if you have one of these factors, you are already classified as being screen positive. And then we have a series of moderate risk factors, and then you become screen positive if you are positive for two out of these 5 or 6 moderate factors. And these factors are first pregnancy, in England, age of more than 40, in the United States, more than 35, a body mass index in England of 35, in the United States of 30, an interpregnancy interval, the interval between this and your previous pregnancy of more than 10 years, it increases your risk, and then a family history of preeclampsia, and in the United States, if you're Black or you're poor. So this is a relatively simple method of identifying a high-risk group, but how good is it? Unfortunately, not very good at all. It is associated with the detection of about 40% or less of the women that will develop preeclampsia, and the classification into a high-risk group of about 10% of the population. And also, it does not give you a personalized risk. It just tells you that you're screen positive or screen negative. So that's what we have in most countries of the world. And then we spent many, many years, like nearly 40 years now, creating this one slide. And what this one slide says is that we get a much better performance if we combine history with a series of biochemical and biophysical markers. For those of you that are interested in screening for Downs, for example, we are back to the 1970s, where the method of screening was maternal age, but then I came up in the 90s with a combination of maternal age with nuchal translucency, free beta HCG, and PABA, demonstrating that that was a much better method of screening. And here, the method of screening is a combination of maternal factors with uterine artery Doppler, mean arterial pressure, and the maternal serum concentration of placental growth factor. And with this method of screening, instead of a detection of about 40%, as with the scoring systems, now we have a detection of 90% of the severe early preterm preeclampsia, 75% of the preterm preeclampsia, and about 45% of term preeclampsia. So it's an extremely good method of identifying a very high risk group for early preeclampsia. And then we carried out a series of studies that had validated that observation, a study of 36,000 pregnancies to begin with, and then another one multicenter study of about 9,000 pregnancies, and another multicenter study in England of 16,000 pregnancies. And what this graph shows, the calibration and validation, is that if a method of screening is good, what you predict turns out to be more or less true. So you are predicting on the x-axis and you are observing on the y-axis. And if you have a perfect agreement between prediction and observation, then you have this linear line or a diagonal blue line. And you can see that for each one of these three multi-center major studies, we found a very good correlation between the three. Now, this is a summary really of the different components of screening. And I just want to quickly draw your attention to, for example, screening and prediction before 32 weeks. If we use maternal history alone in our method, not in the NICE guidelines where it's risk scoring, this is a multi-parameter, multivariate analysis model. We get a detection of 50%. But by adding the mean arterial pressure, we get to 60. If we add mean arterial pressure and uterine artery Doppler, 85, which should not cost anything to your healthcare system, but of course, it requires extensive training of people that perform ultrasound scans. And of course, I know now that your country is actively involved in carrying out such training of as many people as possible. So a combination of mean arterial pressure, measurement of blood pressure, history, and uterine artery Doppler gets you to 85% detection. If we then add PLDF, we get to 90%. PABA does not improve that prediction. With PABA, we don't improve the prediction achieved by mean arterial pressure and uterine artery Doppler. So I think that for Zimbabwe, it is reasonable at this stage to be aiming for screening by history in combination with blood pressure and Doppler. But of course, the ideal method is to add PLGF. I hope that someday soon your economy recovers. The companies that give you the PLGF can give it to you for a reasonable price so that the proper method of screening is instituted. Now, in the clinical implementation, of course, there are many important things that we need to take into account. First of all, we need to measure the uterine artery Doppler perfectly reasonably and in a systematic way. When I introduced the nuchal translucency and people were just carrying out this examination all over the world, I was very anxious that it should be performed properly. So we introduced a method of complete audit of the results and monitoring and training of people. So the scan for the Doppler can be carried out transabdominally. We use color Doppler to identify the uterine arteries in a mid-sagittal view of the abdomen and then in the pelvis, and then we tilt the transducer slightly to the left and to the right so that we can see the uterine arteries at the level of the internal os. And then we put the sampling gate of 2 millimeters to cover the whole vessel. The angle of insonation with any Doppler measurements must be less than 30. And we measure the peak systolic velocity to ensure that it is more than 60 centimeters per second. And then we measure the average pulsatility index of the left and the right uterine arteries. Similarly, there's a standard way of doing the mean arterial pressure. You need to use automated devices. These are about $40, $45. They're not particularly expensive, but they're validated for use in pregnancy. They need to be calibrated at regular intervals. We need to get the women to sit and rest for about 5 minutes with the arms supported at the level of the heart. And then we select the right cuff. If the woman is big, we use a big cuff. And if the woman is small, we use a small cuff. And then we attach the devices, the cuffs on both arms. And we take one measurement. And then after 1 minute, we take another measurement. So at the end, we have 4 measurements, 2 from each arm. And we use the average of the 4 for the prediction. Now, it is very important that there is a regular audit of the results. And this is, in England, what you do for screening for Downs. All of the laboratories and all of the operators, in that case for nuchal, are sending their results to a central lab of mathematicians who look at the distribution of individual laboratories, of individual operators, to see if they are within a certain limit. For example, this green band, in which case they are doing well. If they're in the yellow band, they get a warning to be careful. And if they're in the red band, then they're doing something seriously wrong. And they have to be either retrained or they have to investigate why are they overestimating or underestimating their measurements of blood pressure, Doppler, PLGF. And in different countries, there may be a need for adjustment of the values so that they fall in the normal range. Now, what about prevention of preeclampsia? So this is, so far I have dealt with the issues of prediction. Prevention, many people have tried many things over the last 50 years. Bed rest, restriction of physical activity, restriction of salt intake, supplementation with all sorts of things, vitamins, fish oil, elements, zinc, and so on. None of this has proven to be beneficial. However, in countries that are deficient in dietary calcium, then dietary calcium supplementation is definitely beneficial, and it halves the rate of preeclampsia. So for all of these methods that have been tried, the only thing that works is calcium if you live in a country that is calcium deficient. And now the story around aspirin. Many studies, many studies were carried out in different countries. And unfortunately, I call them the 30 wasted years. And I call them wasted years because they did not systematically examine the value of aspirin. Some of them were using 40 milligrams of aspirin, or 60, the majority of the studies, others 75 or 80, some 100, and hardly any 150 milligrams. And then the timing of the administration of aspirin, some of them were starting rightly in the first trimester after the 12th week, and they were carrying through to the third trimester. Others were just giving aspirin to whoever they liked, whenever they liked. And when this type of studies were combined in a meta-analysis, of course, they produced ridiculous results. They showed that aspirin is hardly beneficial. Perhaps it reduces the risk of preeclampsia by about 10%. I'm not surprised. If you carry out studies that are completely heterogeneous with different entry criteria, different doses, and many different definitions of preeclampsia, it is hardly surprising that nothing appears to be very useful. In the Aspre trial, we were very specific. We wanted to identify properly the high-risk group by the method that I explained, combination of history, mean arterial pressure, uterine artery Doppler, placental growth factor, and then identify the top 10% risk, and then give them 150, not 50 or 40, 150 milligrams of aspirin every night from 12 to 36 weeks in order to get the fantastic results that we got in Aspre. We also found out, of course, something that should be obvious from trials, that if you are allocated into an aspirin group in a trial and you don't take it, of course it will not work. So we looked specifically at the implications of a good compliance. And if the compliance was good, if it was more than 90%, if you were taking the tablets that were prescribed, then the prevention of preterm preeclampsia was not only 60%, but it became nearly, well, 76%. So the better the compliance, the much higher the prevention. We also found out that it doesn't really matter what the primary reason for becoming screen positive is. It doesn't matter whether you are under or over 30, under or over 25 kilograms per meter square in BMI. It doesn't matter whether you're black or white, whether you smoke or not. The impact, this reduction in the risk of preeclampsia was more or less the same, except for one group. In women with chronic hypertension, aspirin did not seem to reduce. If anything, it tended to increase the risk of preeclampsia. So aspirin does not work in women with chronic hypertension. For those women, we have to think of different strategies. So then we carried out a meta-analysis looking at a combination with other studies, and we confirmed really in this summary that for aspirin to be effective and reduce the rate of preterm preeclampsia by 60 to 70%, we need to start it before 16 weeks, and the dose must be 100 milligrams of aspirin or more. Otherwise, it is not useful. If you start after 16 weeks, irrespective of whether the dose is less or more than 100, aspirin does not prevent preeclampsia. Does not. If anything, if you start aspirin late, you may be increasing the risk of abruption. So don't, if you haven't identified the high-risk group and given them aspirin from the beginning, don't start treating them with aspirin after 16 weeks, because the only thing that you may be doing, for sure, you don't reduce the risk of preeclampsia, you may actually be increasing the risk of abruption. Now, is this all worthwhile? Is it cost effective? Or are we just spending a lot of money in screening and a lot of effort for nothing very much? Well, I think the most expensive component of pregnancy care, certainly in England and most developed countries, is neonatal intensive care. If if a baby stays in the neonatal unit for a certain period of time, then it's a disaster. It's extremely expensive. Well, what we showed in the aspirin trial, the blue is the women that had the placebo, the red is the women that had the aspirin. The introduction of aspirin in the high-risk group dramatically reduced the length of stay in the neonatal unit. This is not surprising. We are preventing severe, very early onset preeclampsia. Therefore, we are preventing, to a great extent, severe, very early delivery. So, not surprisingly, you are reducing dramatically the rate of neonatal intensive care. And of course, that is critically important, not only in terms of the cost at the time, but in the long-term consequences. A major study published in the BMJ from France showed that actually the risk of death and disabilities was nearly 20% if you are born at 22 to 31 weeks, and it becomes only 2% if you are born after 32 weeks. And then another major study from Norway, a sort of epidemiological study that looked at the risk of death and cerebral palsy and impairment of work capacity after the age of 20. And it showed that, of course, the earlier you're born, the much greater is the risk that not only you will die in the neonatal period, but also during the first 5 years of life. The much greater is the risk of cerebral palsy if you survive, and the much greater is the risk that at the end of the day, you will be unemployed. So it's a lifelong risk, and therefore anything that you can do to reduce the risk of very early premature birth is worthwhile in all sorts of ways. Now, that is discussing the issues of screening in the first trimester of pregnancy. But remember, what I said is screening in this first trimester picks up about 75% of the women that will deliver before 37 weeks with preeclampsia, and only about 40 to 45% of the women that will develop preeclampsia at term. So the story does not begin and end in the first trimester. We need to be aware that we must continue to monitor pregnancies for increased risk of preeclampsia, especially term preeclampsia. And of course, we have developed complex methods of screening that I try to simplify here. In England, we aim to screen also during the 20-week scan. And I am advocating, of course, that we combine history, uterine artery Doppler, mean arterial pressure, and also PLGF at the 20-week assessment, and then use this information to stratify women into 3 groups based on risk. A very, very small, extremely high risk group that needs close monitoring, every week measurement of blood pressure, a group of about 10% with an intermediate risk where they can be assessed starting at 32 weeks, and the low risk group, which is nearly 90% of the whole population, where you can reassure them that developing preeclampsia before term is very unlikely, but these women can still develop term preeclampsia, and therefore we reassess everybody at 36 weeks. And again, at 36 weeks, we just divide the population into those that are at very high risk and they need to be delivered early to prevent them from developing preeclampsia, an intermediate risk group that can be delivered at around 39 weeks, and the low risk group that can be allowed to carry on conservatively. These are various methods by which I have been trying to rationalize and convert into mathematical formulas the method of screening and management of pregnancies. In terms of the various biomarkers that we have investigated over the last decade or so. Mean arterial pressure is very useful in the first, in the second, in the early and late third trimester. So the measurement of blood pressure in a systematic and proper method is useful. The uterine artery Doppler is useful in the first and second and very early third trimester, not useful in the late third trimester. PLGF is useful throughout. And then, of course, another biochemical marker, FLIT, that is not useful in the beginning, but is useful for later on in pregnancy because it goes up only about 3 to 5 weeks before you actually develop preeclampsia. PAB-A is useful in the first trimester if you don't have PLGF. I just want to tell you of some exciting new research that we carried out, and that is with ultrasound, looking at the ophthalmic artery. It's a very simple procedure. You just put the ultrasound transducer on top of the eye, a linear transducer, not the curvilinear, and then you look at the ophthalmic artery. This is the type of waveform that you get, and you take the ratio of the second divided by the first peak systolic velocity. It takes less than a minute to do. And we found this in major studies now involving 3,000 pregnancies to be predictive of preeclampsia, especially preterm preeclampsia, both during the assessment at 22 weeks and also during the assessment at around 35 weeks. And then I want to finish with the story of twins. The risk of preeclampsia in twin pregnancies is 9 times higher than in singleton pregnancies. And there, we don't really know whether aspirin is useful or not. There have been a few small studies that provided contradictory results. So we are soon to engage in a major undertaking of carrying out screening of pregnancies to identify those that are twins at the 12th week of gestation. We don't want to use biochemical or any other markers. Being a twin pregnancy in itself is sufficient to classify you as being at very high risk. But we need to examine 250,000 pregnancies to identify the 2% that carry twins at the 12th week, to find 5,000. Then there will be a source of exclusion criteria, and hopefully half of the women will agree to be randomized so that we can then see whether 150 milligrams of aspirin starting from 12 weeks can also substantially reduce the risk of preeclampsia in this condition. So I thank you very much for your attention, and I'm grateful for the organizers of your Congress for inviting me to be with you today, even if it is through this method. If people want to ask questions, I will be happy to answer.
Thank you very much, Prof. Nicolaides, for those enlightening lessons. There were a number of questions raised within the chat function. Allow participants to raise their hands and also pose their questions in the chat. The first question was asking about the dose of aspirin, which I think you addressed. I think a number of practitioners have been using a dose of 75 milligrams of aspirin. So the question was whether that was useful or whether 150 milligrams was more useful. And Dr. Verenga had responded to that and said 150 milligrams is useful. And you've also pointed out that more than 100 milligrams is useful. I don't know whether you have any further comments on that.
Thank you very much. I'm now, I don't know if you are seeing my slide here.
Yeah.
Can you see the slide? Yeah. Okay.
Yes.
In England, we were using 75 because that is the dose of the tablet that they produce. In Brazil, the one tablet is 60 milligrams. In the United States, it's 80 milligrams. So actually, people were just using whatever was available. But the original study that showed the value of aspirin from France 30 years ago used 150 milligrams. And we showed that that is the dose that was necessary. In this meta-analysis, let me just take you through it. Less than 16 weeks, less than 100 milligrams, and less than 16 weeks, that's the onset, and more than 100 milligrams. And you can see that with this dose, then you had a 70% reduction, and with this dose, there was no significant reduction. There was an overlap with the vertical line at 1. So 75 is not sufficient. We know that if you take 100 people and you give them aspirin, and then you take a blood sample and you look at the platelet function, in 30 of these 100 women, there would be no change in platelet function. And that is called aspirin resistance. It's not a real resistance, it's just that the dose is not sufficient. If you give 150 milligrams, then this aspirin resistance is less than 5%. So if you're giving aspirin, it should be 150 milligrams.
Thank you, Prof. Nicolaides, for that response. Prof. Munjanja, you have raised your hand. You can go ahead.
Thank you, Chairperson. Thank you, Professor Nicolaides, for a very good presentation, state-of-the-art lecture on screening for preeclampsia. I'm sure you won't remember me. I came to your course in 1988 at King's College. At that time, the fetal medicine course was 2 weeks, not 18 months as it is now, or 2 years.
We tortured people at that time, I remember.
Yes.
We kept people from 8 o'clock in the morning until 2 o'clock after midnight. And the people that survived learned something. So thank you for reminding me, and thank you for coming then. Yes.
Thank you. And also thank you to Dr. Verenga for his presentation on the same topic. I just want to make a comment about the early booking, the booking gestation.
Yes.
In Harare, the median booking gestation is around 22 weeks. But if you do studies in the rural areas, rural women book much earlier than urban women. And this anomaly is caused by the fact that we have inverted the pyramid for referral. What has happened is that the municipalities, the urban municipalities, are still insisting on charging women for maternity care. But at the tertiary hospitals and the district hospitals, the care is free. So there's no inducement for women to book early, because if they want to book early, they have to pay the clinics in the municipalities. But if they wait until the end of the pregnancy, they can come to the hospitals unbooked and be delivered. We have known about this problem for a long time. It is an administrative problem which should be solved at the policy level. And that is why we have failed to reduce the booking gestation for women in urban areas for nearly 30 years.
That's thank you. I mean, that's an incredible observation. 3 years ago, in our Congress in London, we had the health minister from Zimbabwe who came, and he was very, very enthusiastic. Of course, politicians are always sometimes enthusiastic, but then their enthusiasm is not necessarily translated into action. And he was very, very positive in terms of the concepts of the inversion, as you called it also, of pyramid of care, so that we see women early and we try to identify and prevent problems rather than seeing them late when they have already developed problems. But I'm sorry if I have interrupted you. You wanted to say something more.
Prof. Munjanja, did you want to say something further? Okay. I think Prof. Munjanja has muted himself. There were 2 further questions posed within the chat. The first one from Dr. Guja: why do you think aspirin didn't work in chronic hypertensive women? And how do we mitigate this risk in those women? Prof.
Thank you, very good question. I don't know why it didn't work. I suppose the mechanism of development of preeclampsia in women with chronic hypertension is different than those without chronic hypertension. Despite the fact that chronic hypertension in itself is the most important risk factor in terms of preeclampsia, about 10 to 20% of women that start off the pregnancy with chronic hypertension will develop preeclampsia. So here we are, a very sad situation, as shown in this slide. The most high risk factor is the least one that can prevent preeclampsia through aspirin. Now, for many, many years, there was an attitude in the management of chronic hypertension that we must not lower the blood pressure too much, because if we do so, we will produce growth restriction. So people tended to allow these women to carry on with blood pressures of 140 or even 150 over 90 or even more before they will try to reduce their blood pressure. That has now been proven to be wrong. And certainly in people outside pregnancy that have chronic hypertension, the attitude now, in order to reduce the risk of long-term myocardial infarctions and cardiovascular disease, is to be very aggressive with blood pressure control. The aim is to really not allow a blood pressure to run at 140 or more over 90, but to dramatically reduce it to 120 over 80 or even less. This is in non-pregnant individuals. And I think that the same must be true for chronic hypertension. We haven't carried out the appropriate study. We haven't done a randomized study, but I believe that in the future studies will be focusing in terms of randomized studies where we aggressively control the blood pressure of chronic hypertensives starting from the first trimester to see whether you can reduce the risk of subsequent development of preeclampsia. So not aspirin, aggressive control of blood pressure from the beginning.
Thank you, Prof. Dr. Guja, I think you are well answered. Let me know if you want him to explain further. We are joined from participants from all over the world, which is one of the advantages of being on a virtual platform. We have a question from Dr. Cooper at Tabazimbi Hospital, who says, when should aspirin be taken, day or night?
Thank you. This is a tricky one. Because traditionally we're telling people just take the aspirin in the morning with your breakfast. And then there were some studies from Spain, which raised the possibility that maybe aspirin taken at night is more beneficial in terms of regulating blood pressure. So in the Aspre trial, we gave the aspirin at night. Now, we didn't actually randomize patients into morning or lunchtime and night. We used the data from Spanish randomized studies, and therefore we gave the aspirin at night.
Thank you. The next question is there any role for aspirin in pregnant women with polycystic ovarian syndrome in view of their increased risk of developing preeclampsia?
Again,
so that's
yes.
A question in the chat.
Yeah, the polycystic ovarian disease also comes as a package, also often with obesity. And again, this type of women will be at a particularly high risk of developing preeclampsia. So it is reasonable, yes, to give them aspirin.
Thank you very much, Prof. Are there any further questions? If you have a further question, may you please raise your hand. In the meantime, if any participant requires CME points, there is an email address that has been posted on the chat. You can email that email address and you'll get your certificates early next week. I don't see any further questions on the chat or any further raised hands. Prof. Nicolaides, thank you very much. I am absolutely starstruck and I've learned a lot this morning. Thank you very much for enlightening us this morning.
Thank you for giving me the opportunity to communicate with friends in Zimbabwe. All the best to you. Thank you.
Thank you. So we'll move on to our third speaker for this session. Our speaker is Telle Ukonaho, and I hope I've pronounced that correctly. If I haven't, please forgive me. She's based in Finland. She has a master's degree in the field of molecular biotechnology and in vitro diagnostics. For over 10 years prior to joining PerkinElmer, Telle Ukonaho worked with the R&D teams and other programs as a development chemist and a project manager, covering programs related to the development of different neonatal and prenatal screening solutions. And among these initiatives, she led the project to launch the first Preeclampsia first trimester screening solution in the market. After a successful achievement with the best performing placental growth factor assay, she decided to take her expertise to support adoption of preeclampsia prevention programs and joined the reproductive health business unit at PerkinElmer, where she's currently the global product manager. It's my pleasure to present Telle Ukonaho to speak about preeclampsia screening solutions.
Thank you very much. And it is an absolute pleasure to be here. Thank you for the invitation. And it's an absolute honor to be also speaking within this group after, especially after Kypros Nicolaides. I will share my screen. Hope you can see it.
Thank you. I think we can see it.
Okay, good. And thank you for the introduction. So, and greetings from the cold and dark Finland. So it is a pleasure to be speaking to the other side of the world today. As we have learned today, preeclampsia is not a rare disease. It is considered to be one of the leading causes of maternal and perinatal morbidity and mortality. And it is affecting a huge amount of pregnancies each year, and what we learned today after Dr. Verenga's speak is that it is also affecting heavily pregnancies in Zimbabwe. The numbers that he showed were tremendous, and there is certainly a room for better care and better management of pregnancies. And if it's not treated, it can cause premature delivery. It can end up with eclampsia and even death of the pregnant ladies. And but with better screening, better management, we can make substantial improvements to the maternal and fetal health, and also influence to the risks that are lying there after these risk pregnancies. If we are looking at the number of preeclampsia globally, what it is, how it is affecting globally, we already learned that it is affecting the death of these pregnant ladies. 76,000 women each year is losing their lives. The numbers, how it is affecting pregnancies, it's even higher. 10 million women globally are having preeclampsia each year. And if we are turning that into numbers of minutes, a time frame, every 7 minutes there is somewhere in the world one woman losing their lives. And this is all for nothing, because we could be preventing these deaths. It is not only a condition for mothers, it is also infecting the babies. We learned today that 500,000 babies are dying globally because of the preeclampsia, but the numbers are even higher if we are looking how many preterm births there are happening in global level. 2.5 million babies are born prematurely, and we learned also today that there are a lot of complications after born when these babies are born prematurely. And actually, if we are looking at Africa, there are numbers published for Africa also. So 66% of all the deaths in global level are happening in sub-Saharan Africa. We also learned earlier that the effects of preeclampsia are not only the short-term consequences for the mothers and the babies during pregnancy, but there are also the long-term consequences happening. So for mothers, there are increased risk of developing chronic diseases like diabetes mellitus, hypertension, cardiovascular disease, and stroke. And the lifetime expectancy will be reduced also. For the babies, we learned from Kypros Nicolaides' wonderful presentation that there are a lot of consequences after the preterm birth, and the earlier the baby is born, the severe are the consequences. So this is not only a condition that we should be looking at during the pregnancy, but also after the pregnancy. I also wanted to bring up a few last slides why we are screening. So it is important to bring here the sort of the justification for the screening, which is this is something that is still, even though it was already presented in 1968 by Wilson and Jungner, the criteria for disease inclusion in screening programs, it is still valid today. So the main points in this screening program disease inclusion criteria was that the disorder that we're screening should be important health problem. There should be an accepted treatment. It should be important to screen early. There should be a suitable test available, and it should be cost effective. If we are looking at preeclampsia and Down syndrome, we know that Down syndrome, for example, it is widely accepted to be screened globally. There are differences between different countries, but in overall it is very well accepted. The prevalence of Down syndrome is 1 to 700. It affects only the fetuses, and when there is a screening positive baby, the only intervention is the termination or for the baby. Preeclampsia, the preterm preeclampsia, the incidence is 1 to 145, which is much higher than for Down syndrome. It affects not only the fetus, but also the mothers, and there are the long-term consequences. And when there is a screening positive pregnancy, the intervention is to treat the pregnancy, give aspirin, and to gain better surveillance for the mothers and for the babies. So preeclampsia is basically meeting all the screening criteria that are placed for the guidance with Wilson and Jungner. Then we also learned about the what is the traditional way of screening today and what are the guidelines stating today. As presented in both of the previous presentations, the traditional method for screening is to identify the high risk factors for the pregnant lady based on the maternal historic data, maternal characteristics. These are recommended by the AGOG and the NICE guideline, as was told already, and the detection rate is around 40% with the false positive rate of 10%. This is still what I learned earlier from Dr. Verenga's presentation also, is that these are the methods also basically used in Zimbabwe. So we have room for better treatment, better screening and better methods for screening preeclampsia. We also learned earlier, briefly going back to the previous presentations, that there has been a long road until today with all the studies and work that has been done to be where we are today. So building the evidence has taken a long time. We as a company, PerkinElmer, we started even earlier than 2010 building the evidence, but the first kit that was available was in 2010. And that was the kit that was actually used for Aspre study. So Delphia Express PLGF kit was available, and we were developing that especially for the first trimester screening to meet all the requirements that the low PLGF levels during pregnancy and even lower when there is a preeclampsia are setting for the assay. So our PLGF was used as a part of the combined screening. As Professor Nicolaides already told, there is the need to combine different factors: maternal history, the blood test by PLGF, mean arterial pressure, and then the uterine artery Doppler. And based on these biochemical markers that we get from these 4 pieces of the screening, we can combine that in a risk and get the value whether the woman has a high risk or not for preeclampsia. Then he told us about the Aspre project, which was still today the biggest randomized, blinded, randomized multi-center study that has been to proven the efficacy of combined screening and also the efficacy of the aspirin treatment for these high-risk women. And he also told about the successful prevention results from the Aspre study. So they were able to lower down the rate of preeclampsia heavily. And there has been a lot of publications after that showing how the compliance was affecting and how the prevention affected to the stay in the NICU care also. After this Aspre study, later on, there was the following years coming, and also international guidelines were published. ZSOG has their own guidelines, and FIGO also has their own guidelines, and both of these guidelines are actually recommending the same combined screening model as was used in the Aspre study. And I also wanted to point out that in the Aspre study, the blood test and the risk blood test BLGF 123 was that, and the instrument for that was provided by Perkin-Elmer. Okay, this we can skip. He also, Professor Nicolaides, mentioned about the NICU study that was done. I also wanted to point out that the study showed us that by reducing the length of stay in the NICU care by about 70%, it lowered down the healthcare costs also, and it increased the infant survival rate. There has been a lot of discussion whether the screening is cost efficient. Of course, it is more straightforward to show it by lowering down the healthcare costs, but there is also the factor of the infant survival and better outcomes for the mothers also, which we cannot calculate in money. That is something that we need to also remember. He also mentioned, I'm referring to Professor Nicolaides again, that the preeclampsia itself, it is a complex disorder, and there is considered to be two different modes of, if I can say so. So there is the poor placentation, or the term preeclampsia, which is caused more or less from the metabolic dysfunction of the mother. So what we are able to influence with the screening and prophylactic use of aspirin is the poor placentation, which are happening before 37 weeks of the preeclampsia, of 37 weeks of gestation. This is also just to show that the international guidelines for first trimester preeclampsia screening are there, and there are recommended model the combined screening. And both are also suggesting the taking the aspirin dosage as it was proven to be the best way in the Aspre study. But then, what if we don't have all the bits and pieces that are needed for the combined screening? So there are different combinations that we can use depending on the resources that we have available. We also learned that the maternal history only, it gives you about 50% of the detection rate. But adding different biomarkers on top of that, we can reach out to different detection rates. Of course, the best model would be to have the maternal history with BLGF, blood pressure, and the ultrasound, giving us the almost 80% of detection rate. But then again, if we don't have all of these biomarkers available, it is better to do something than nothing. So I learned also today that Dr. Verenga's group has been doing a lot of good work with the ultrasound. So it is possible to start with the maternal history that you basically have already in use with the methods that you're using with your questionnaire also, but then to add their blood pressure measurement, as Dr. Nicolaides was teaching to do it properly, and then to have the uterine artery Doppler, you are able to start well enough. And then we are providing you very happily the PLGF on top of that, and there you have the combination. So coming back to the criteria of screening, so we can basically we can conclude that preeclampsia meets all the screening criteria, and there is no need, no reason to be not screening. Then Professor Nicolaides was also touching the base with the second and third trimester. So I also agree that we're not ending in the first trimester. We need to follow up the ladies also at the second and third trimester. So the first trimester is the key. There is the chance to prevent the preeclampsia happening, which is the most important thing to do. But of course, we are talking about screening, and there are always ladies that either don't show up to the clinic early enough or are missed by the screening. So we need to have tools also to manage the preeclamptic ladies later on in the pregnancy when they show up to the clinic with suspected preeclampsia and with all the symptoms that are very unspecific, and the identifying whether there is preeclampsia or not is hard for the doctors even today. So what we are offering for that, so for the first trimester, we also, of course, we are offering the instrumentation, the PLGF kit, and also the risk calculation engine to do the prediction and prevention for all women. But then for the management of preeclampsia on the second and third trimester, we have the PLGF that can be used alone for the identifying the ladies that have preeclampsia already, or for the screening, as was taught by Professor Nicolaides, that there is a model for screening also at 22 weeks and 36 weeks of pregnancy with the model he was showing today. Then there is a possibility to also for use to aid in diagnosis and short-term prediction, the SFLT-PLGF ratio. And then we have also a point of care test to be used as a combination with these two other biomarkers, split PLGF, which I will tell you later. So what are we using PLGF and split PLGF ratio in second and third trimester is to identify the ladies and do the short-term prediction for the ladies, whether they will develop preeclampsia in near future and whether they have already preeclampsia on. And this is to do to reduce the frequency of adverse outcomes and also decrease the healthcare cost decrease the unnecessary hospitalization for the ladies. And the most important thing is to shorten the time to get the lady treated, because the condition of these ladies which are having preeclampsia can go worse very, very quickly. There is most of the data today available for the management of these ladies is with this split PLGF ratio available. So there are a lot of publications how to use that to rule out and to rule in and to monitor the ladies. But there are also studies how to use the PLGF alone for the second and third trimester to rule in and rule out. So there are publications showing that with our PLGF 1-2-3 kit, it is as effective and as well working for the rule in rule out as split PLGF ratio. So there are a simple cutoffs for in and ruling out the ladies. So what 50 picograms per milliliter to rule in and 150 picograms per milliliter to rule out. Then we have also this point of care test, Congrad point of care test device for aiding diagnosis. This is a simple method that could be used as a combination for the previously mentioned SFLIT and PLGF. So this is a yes/no device which can be used where you don't have laboratory, for example, available. This is urine based and it gives you results in 3 minutes. There is no instrumentation needed, and it can easily detect simply by adding the urine into the test device whether you have already preeclampsia on or not. So this is used as a combination. This is not a quantitative test, this is qualitative, so yes or no. And this every time when you have the device positive, you should also later on use the biochemical markers to follow up the pregnancy. This might raise some questions how this is working then. So this is based on a dye called Congrad, and when there is a preeclamptic pregnancy, there are in the urine misfolded and aggregated proteins present, and this dye is attaching to these misfolded proteins. So in this picture here, there is a normal pregnancy without any preeclampsia. So there are no misfolded proteins available. And that's why the dye is not attaching to the urine, which is migrating on the membrane, and it stays in the middle. But if there is a preeclamptic pregnancy with the misfolded proteins that are migrating with the urine at the membrane and forming a wider spot, also the dye is migrating with the urine. So you can, based on that, distinguish whether there is preeclampsia or not. This is very powerful method also. There is a high negative predictive value, which means that this is a good tool to rule out ladies. So if there is a symptomatic woman and you do the test and this shows negative results, you can easily, with a good conscience, send the lady home with knowing that this was not preeclampsia. So how does this help? This helps that it enables the fast triage. So it is only 3 minutes to perform the test, and it is really specific for the preeclamptic ladies, and it is easily available in any condition. And this is just to state that these are solutions complementing each other. These are not replacing each other. So the point of care device is qualitative and for the aiding identifying preeclampsia from the 20 weeks onwards until the delivery, and it doesn't need any extra instrumentation. And then there is for the ladies also, whether you have had point of care device in use or not, there is the tools for quantitative measurement where you know based on the result and the value you get out, what kind of condition is ongoing, how bad is the preeclampsia. And this is to be used also together with the point of care device to confirm the preeclampsia and to follow up and manage the preeclamptic ladies. The other one is from urine, and the biochemical markers conventionally used are from serum. Again, to show what we offer, so we offer the PLGF kit that was mentioned many times, and our PLGF is for all trimesters. So it is validated originally for the first trimester screening, but later on we also validated that for second and third trimester of pregnancy. So you can use it throughout the whole pregnancy time. And because we were validating that for the first trimester, it is highly sensitive, the most sensitive kit available today for the measurement of PLGF. And we also have validated that for aiding diagnosis with the suspected preeclampsia. PLGF from us is also validated for the Down syndrome screening. So if you're doing already Down syndrome screening and you want to add on PLGF, you will benefit twicely. So you can add on the detection rate for the Down syndrome screening and also start screening preeclampsia with PLGF. And also to mention again, it was the kit that was used in the groundbreaking Aspre study. There are 2 package sizes available for different platforms to accommodate the different throughput needs. So if you have very low number of samples coming in, you can start with platforms that you can use also with the low numbers of samples. Then we have the SFLT, and I don't know what has happened to my slide because there is the for some reason it's not showing. So if you don't mind, I go through by this way. So there is PAPA also available, validated both for Down syndrome and preeclampsia screening. But as Professor Nicolaides concluded already, we know that PAPA is a powerful tool and powerful marker for Down syndrome, but it is only to be used in the preeclampsia screening when there is no PLGF available. It is not adding to the detection rate that much. There are also 2 package sizes available similarly to with PLGF to accommodate to the throughput needs. Then there is SFLT, which is to be used as a combination with PLGF. It is not to be used alone so far. There are also 2 package sizes available and can be used together with the PLGF for the symptomatic woman for aiding diagnosis and for short-term prediction. Then we have in our offering native serum controls. So for the PLGF and for SFLT, we have, these are 2 different control packages that we can offer for the quality follow-up to secure that when you're doing your screening and doing your assays, the quality is in the right level. Then we have the point of care device with Congored, which is used as a combination and add-on or in conditions where you don't have the ability to use these biochemical markers like PLGF and SFLT, then you can also utilize, when there's nothing else available, this Congored test for identifying the ladies. But to mention, this is not for screening. The key is to screen in the first trimester with PLGF. Then I go back to my presentation mode. Oh, there it was. Then we have also the life cycle, which is a risk calculation software. It includes the risk algorithm that is validated by FMF. So the same algorithm that was used in the Aspre study is also in our life cycle software. And as mentioned by Professor Nicolaides, it is very important that there is the ability to follow up the quality of the screening. So you need to follow up how your medians are staying stable, or then there might be a need to adjust a little bit. Then there is a need for population specific medians, and this software is supporting all of these factors that were mentioned. This is really flexible calculation program, and you can configure it based on your needs very easily. So you can add on different functions based on what you want to follow. And it is also nowadays including the possibility to follow up the ladies from the first trimester until the end, because we have added also the SFLT PLGF ratio follow up there. So it calculates automatically you the ratio, and if there is a need for repeat measurements, for example, it lists all for under the same patient, so you can follow up the lady during the whole pregnancy in the same program. And you can also add there the measurements from mean arterial pressure and uterine artery Doppler. So you can configure it to be connective with the third-party applications. So we are a complete solution of offering complete solutions. So we are offering the different instrumentation. So there are, for the small needs, the Victor D, medium need, Delphia Express, which is the platform used in the Aspre study. It is a random access analyzer, so it is very easy to be used in like, if you know what is an Oscar clinic, where you have the flow where you take the lady in, and you within an hour the lady has the risk assessment done, and all the needed actions done within 1 hour. So this is the one that you can use for that. So when the lady comes in, you can do the collect the maternal characteristics and take the blood sample, and while the lady is doing the blood pressure measurement and the uterine artery Doppler, the instrument is analyzing the biochemical markers, and then the risk calculation is done with the life cycle. And when the lady is waiting and until she's sent home, there is already the risk assessment done and the discussion with the doctor also done. Then there is the high throughput device, which is the AutoDelphia, which can process these samples also from various biochemical markers. So all of these, actually all of these platforms are also capable of processing samples that are for Down syndrome also. So the same sample goes for both of these conditions, but there are different analytes that are measured. So all the Down syndrome markers are also available for these platforms. Then we have the point of care kit also available for the different needs and different conditions than the lab-based products we have. And this is just to show that we are really trying to cover the whole pregnancy and preeclampsia management, and we try to offer all the different for all different needs. So there is the combined screening protocol where we are supporting with the kits, the instruments, and the software. And then there is the aid in diagnosis, which we are supporting with also the software and the kits and the instruments. So we are happy to provide all these bits and pieces. And in addition to these sort of materials that we are providing, we are also providing a lot of training and support, and we are helping our customers how to set up screening and what are the things that you need to consider when you are in a process of starting the screening program. And we are also happy to come and discuss with the ministry level and all the stakeholders that are involved in this process. And so we are supporting you all along the whole journey. So this was basically what I had to tell about our products. And if you have any questions, I'm very pleased to answer to all of your questions. So thank you.
Thank you very much, Telle Ukonaho, for that very informative presentation on the molecular methods available to us to screen for preeclampsia. There is a question in the chat box while I'm waiting for people to raise their hands or type more questions. The question is from Dr. Cooper again. What are the cutoff values of the PLGF S-split ratio and the risk for developing preeclampsia?
Okay, that is an interesting question. Thank you for asking. So what we have done with our S-split PLGF ratio solution, we have, of course, we have the PLGF alone where the cutoffs are different, but for the S-split PLGF ratio, we have this starting point that have a relation with the currently available other commercial assays. So you can start with those cutoffs, but of course we are recommending that every laboratory should base their own cutoff values for each methodology that they are using. We are helping with that process, but because we know that preeclampsia, there are different factors affecting to the values what you're getting. So PLGF, SLIT, both are affected by the ethnicity and the population that we are measuring. So for that reason, we are guiding you to measure your own laboratory specific values. I hope I answered to the question.
Thank you. I hope you answered, Dr. Cooper. Thank you once again. I don't have any further questions, Telle. Thank you once again for your very insightful presentation. It's 1:03. We've had a very productive second session. Dr. Verenga spoke about his work in pioneering fetal medicine in Zimbabwe and how he's taking us to modern practice. Prof. Nicolaides highlighted lessons from the Aspre trial, and now we know that the most effective dose is 150 milligrams of aspirin taken at night from 12 to 36 weeks. And if you start aspirin after 16 weeks, you're likely to increase the risk of abruptio. And Telle has enlightened us on the molecular methods available for screening for pre-eclampsia. Thank you so much.
Dr.
Okay. Apologies, sorry, I missed the question. Yes, Dr. Verenga.
Thank you, Dr. Gwanzira. I just wanted to thank Telle for taking time to present and also to show us that there are solutions to our problems of pre-eclampsia which we can adopt. I just want us to know that I think starting next year, in the fetal medicine units, we'll be teaching people how to do the mean arterial pressure, because I think from the presentations done so far, we might not be able to do uterine arteries Dopplers for most of the patients, but those who are seen in fetal medicine need to be done. But the mean arterial pressure, I think, is something which is doable because blood pressures are being done anyway. But what we need is not the absolute value of the blood pressure, but the mean arterial pressure, which people can be taught how to come up with the mean arterial pressure so that the risk for pre-eclampsia can be done based on history and also the mean arterial pressure for the moment. Thank you.
Thank you very much. It has been a real pleasure.
Thank you. Then one more question to Telle. Telle, if yes. I may ask you probably in front of the audience, saying, if PLGF is to come to Zimbabwe, how much do you think it will be the retail cost for the patients? How much will the PLGF cost? I mean, at the level of the patient.
Well, there are different models, so I can't give you an exact answer in this point. It is not. There are different models of what we are offering for the customers. So there are different ways of, like, if you have a reagent rental deal or if you have a CapEx deal. It depends a lot based on the deal you are making with the manufacturer. So I'm sure that we can come up with a good solution. So yeah. I'm sorry, I can't give you a better answer in this in this moment.
All right, thank you.
Thank you.
Thank you very much to our speakers and our participants. This is the end of our second session. We'll break for lunch and return to commence our third session at 1400 hours. During the lunch break, our sponsors, Mindray, will be showcasing their selection of solutions to aid our practice. So thank you. See you at